This is Dr. Aditya Sibi Chakravarti from Dr. Talks. Today we will be dealing with the third topic in rheumatology, that is the antiphospholipid syndrome. So first, what is this antiphospholipid syndrome? Antiphospholipid syndrome is basically an acquired hemophilia. There will be a high chance of blood clotting because of presence of certain antibodies. Because of these antibodies, there will be increased chances of forming blood clot, and this blood clot can lead to arterial clotting, venous clotting and pregnancy problem. So this is what is the basic Apla syndrome. So what is the primary Apla syndrome? Primary Apla syndrome means there is only the presence of antiphospholipid anti-syndrome. In secondary Aplas, this Aplas can be associated with other conditions like systemic lupus erythematosus. That is the most common association. This Aplas is basically seen in more common in a young female population than other population. So what is the catastrophic APLA syndrome? There is a simultaneous involvement of more than 3 organ systems. It is a devastating form of Aplas involving more than 3 organ systems. That is what is called as the catastrophic APLA syndrome. So what are the 3 antibodies that is seen in antiphospholipid antibody syndrome? The 3 basic antibodies are the antibody against the lupus anticoagulant. This is the first antibody. This lupus anticoagulant, this cannot be directly found out. This can be identified by prolonged APTT and PT by a special test called as dilute Russell venom pipette test. So this is the first antibody. Then second one will be the anti-beta-2 glycoprotein antibody. This beta-2 glycoprotein antibody can be found by ELISA method, and it is also very sensitive in the diagnosis of APLA syndrome. The third antibodies will be the anti-cardiolipin antibody, direct against the cardiolipin antigens. These 3 antibodies are classically found. They together count as the antiphospholipids, and they are classically seen in patients with Apla syndrome. They can also have other evidence of VDRL positive or RPR positive, but they are not major. These 3 antibodies will be the major one. So why the patient develop Apla syndrome? There will be some endothelial injury and exposure of the phospholipids because of stress or infection or some inflammation process. There will be endothelial injury and exposure of the phospholipids, and there is formation of this antiphospholipid antibody. This will cause a procoagulant effect and leading to clotting in various organs. So what are the clinical features? A young female presenting with evidence of venous thrombosis. This can be superficial vein thrombosis, a deep vein thrombosis, and a consequent pulmonary embolism. They can present in that way, or it can cause thrombosis of the inferior vena cava causing Buchiari syndrome, or thrombosis of the renal veins causing glomerulonephritis, or a thrombosis of the pulmonary artery causing pulmonary hypertension, or thrombosis in causing levator reticularis of the skin. Any venous thrombosis is possible. Arterial thrombosis, it can cause the CNS manifestations in the form of stroke, transient ischemic attack, retinal artery infarct causing amaurosis phagox, or it can cause myocardial infarction, or a peripheral arterial disease form of recurrent peripheral ulcers, non-healing peripheral ulcers. These findings are presented as related to arterial thrombosis. Then musculoskeletal manifestation in the form of myalgia, arthralgia, arthritis, muscle infarction, or it can be to the bone infarction, bone marrow necrosis. Everything is possible. Then blood manifestations in the form of anemia or autoimmune hemolytic anemia and thrombocytopenia, they can occur in such patients. The pregnancy problem, it can either have increased risk of pre-eclampsia, increased risk of eclampsia, increased risk of preterm birth. Then there can be increased history of abortions. There can be evidence of spontaneous abortion, or there can be evidence of preterm births because of this placental insufficiency. So what are the sometimes they can also cause glomerulonephritis in the form of hematuria, proteinuria, raised blood pressure, raised urea creatinine. This can be present, and they can form endocarditis. When they are associated with SLE, they can cause limb and sex endocarditis, which involves both the sides of the wall leaflet. So how do you diagnose this APLA syndrome? Mainly the clinical criteria and the lab criteria, both of them are used. For clinical criteria, there is 2 things. First, the vascular problem. Vascular means there should be evidence of more than one involvement of either arterial thrombosis or a venous thrombosis or small vessel thrombosis and consequent organ or tissue injury. More than one episodes of clinical thrombosis, that is the vascular criteria. Pregnancy criteria means 3 points. The first point will be the more than one 3 or more consecutive spontaneous abortion of unexplained cause less than 10 weeks. That is the first point. The second point will be more than one preterm delivery before 34 weeks of gestation because of preeclampsia, eclampsia or placental insufficiency, or more than one unexplained fetal loss more than 10 weeks in a morphologically normal fetus. These 3 are the pregnancy criteria. The lab criteria will be these three antibodies: anti-lupus anticoagulant, antiphospholipid antibody, anti-cardiolipin antibody, antibody-glycoprotein antibody. This antibody should be having high titers and 2 consecutive measurements which are measured more than 12 weeks apart. So persistent high antibody titers can help in the diagnosis of lupus anticoagulant, of APLA syndrome. So how do you manage APLA syndrome? Well, to the first evidence of thrombosis, the patient should be started on anticoagulation. Warfarin should be started at a dose of 5 mg. You have to maintain the PTINR between 2.5 to 3 after the first episode of thrombosis. If the patient is had a first episode of thrombosis, started on warfarin. Again, if he is developing second episode of thrombosis, he should have a higher PTINR of 3 to 4, 3.5, around 3 to 3.5 PTINR should be maintained in such patients. So pregnancy, the patient should receive heparin with a combination of aspirin. Heparin combination should be given right through the pregnancy. After the pregnancy, you can shift the patient to warfarin because warfarin is notorious to cause warfarin embryopathy in pregnant female. IVIG. What is the role of IVIG in APLA syndrome? If the patient have got catastrophic APLA syndrome, or if the patient having refractory to steroid administration, then IVIG can be given at a dose of 400 mg per kilogram per day for a duration of 5 days. It can be used in refractory conditions. Then the other group of patients, the patient has a high risk for clotting events, but there is no clinical evidence of clotting as of now, and the patient has a positive lab pictures. Positive anticardiolipin or phospholipid lupus anticoagulant. If the antibodies are positive, these patients should be started on aspirin 75 mg or hydroxychloroquine 200 mg to reduce the clinical events. If the patient develops HIT syndrome, heparin-induced thrombocytopenia, then both heparin and low molecular heparin are contraindicated. The patient can be started on rivaroxaban 10 mg OD or fondaparinux can be given in such patients. So, any young female presenting with recurrent episode of arterial thrombosis or venous thrombosis or pregnancy loss, you have to think of APLA syndrome. Send the patient for the 3 antibodies. If the 3 antibodies are, if one of the 3 antibodies are positive, and you have to diagnose the patient to be APLA syndrome and start to put the patient on warfarin. The patient has got lifelong anticoagulation, put them on warfarin and maintain the PTINR. If the patient is undergoing pregnancy, shift the warfarin to heparin plus aspirin throughout the pregnancy, and you should monitor for the PTINR and APDT monitoring. So this sums up our discussion on antiphospholipid antibody syndrome. I hope this was useful. If you find this discussion to be useful, I would like you to subscribe to my channel. I would like you to share this video with all your friends. Support the page. Thank you.